Good day, everyone. I'm Dr. Ayla Esmerjan Suite Torres, and we will discuss about bias and confounders. At the end of the session, you should be able to first define internal and external validity. Second, to differentiate random errors and systematic errors or bias, as well as explain how they affect the research validity. Third, to describe different sources and types of systematic errors or bias and ways to control them. And lastly, to explain how confounding variables influence the results of a study. Let us first define what is internal validity. Internal validity refers to a degree to which a study establishes the cause and effect relationship between the treatment and the observed time. Conversely, it refers to the degree to which the absence of a relationship implies the absence of the cause. In a study that lacks internal validity, the results are probably attributable to a cause other than the treatment. Internal validity is important because once established, it makes it possible to eliminate alternative explanation for a finding. If we implement a smoking cessation program, internal validity ensures that any improvement in the subjects is due to the treatment administered and not something else. On the other hand, external validity is the extent to which you can generalize the findings to different groups of people, situations, and measures. It is the degree to which inferences and findings from a sample can be extended to the target population. This is important because if external validity is established, it means that the findings can be generalized to other similar individuals or populations. Internal validity of an epidemiological study can be affected by random error and systematic error or bias. So let's now differentiate the two. Random error is a measurement error that fluctuates due to unpredictability or uncertainty inherent in measuring process. Random error isn't necessarily a mistake, but rather a natural part of measurement. There is always some variability in measurements even when you measure the same thing repeatedly. Because of the fluctuations in the environment, the instrument, or your own interpretations. Like in the first figure, some may measure it as 25, some will be 26. It is important to take note that random errors can be minimized by increasing the sample size. Systematic error or bias results from persistent issue and it leads to consistent error in measurements. So it is the proportional difference between the observed and true values of something. The figure on the right shows a systematic error due to instrumental factor. It can be noted that due to the imperfection of the measurement structure, it can cause false result in the study. Bias is defined as trend or deviation from the truth in data collection, analysis, interpretation, and publications which can cause false conclusions. This may result from the methods used by the investigator to recruit individuals for the study or what we call the selection bias, or may result from systematic distortions when collecting information about exposures and diseases or the information bias. Unlike the random error, this cannot be minimized by increasing the sample size. So as what I have mentioned on the previous slide, bias can either be selection bias or information bias. So let us now discuss each of these biases. Selection bias refers to systematic distortion in the process of selecting participants for a study, resulting in non-representative or biased sample. In most cases, certain individuals or groups are more likely to be included or excluded from the sample, leading this inaccurate or misleading conclusion. In this case, the sample that you have may not be representative of your population. So to give you an overview, this slide shows the different types of selection bias. These are the non-response bias, the Neyman bias, loss to follow-up or dropout bias, Bergsonian bias, sampling or volunteer bias, and the sample size bias. So let's discuss them one by one. For the non-response bias, this occurs when individuals selected to participate do not respond or choose to participate. Individuals who do not respond to invitations are likely to do different from the individuals who do. Hence, non-respondents must be compared with respondents about key exposure and outcome in order to ascertain the relative degree of non-response bias. So, for instance, if a survey on income is only completed by individuals with higher income, it can lead to an overestimation of average income individuals. The incidence or the prevalence bias, or otherwise known as the Neyman bias, is a selection bias where the very sick or very well or both are erroneously excluded from the study. Excluding patients who are very sick or died will make conditions look less severe. So on the other hand, excluding patients who have recovered will make it more severe. For example, a study of patients hospitalized for the flu will miss those patients who have died and those who have been discharged after recovery, skewing the results towards individuals who are average. So the next type of selection bias is the loss to follow-up or dropout bias. This is associated with cohort studies that can introduce bias if the individual lost to follow-up differ with respect to the exposure and outcome from those persons who remain in the study. This can either be random or systematic or the attrition. Random means that participants who stay are comparable to the participants who leave. This is the case if the dropouts from the control and the experimental groups are roughly equal. Systematic or attrition where is when the participants who leave differ in specific ways from those who remain. So true relationship between exposure and disease will only be distorted if the losses during follow-up or the selective or the non-random with respect to both exposure and outcome. Another type of selection bias is Bergsonian bias, which is also referred to as hospital patient selection bias, Bergsonian bias, or the Bergson's paradox or Bergson's fallacy. This is often encountered in a case control study wherein the bias tends to cause the odds ratio to be underestimated. For example, patients in the hospital can have diseases aside from your disease of interest, which can model the investigation that you are conducting. Sampling or volunteer bias occurs when some individuals within a target population are more likely to be selected for inclusion than others. It is likely that those who volunteer will not be representative of the general population since volunteers tend to be more health conscious than the general population. And lastly, the sample size bias if there is inability to detect differences in study groups arising from inadequacy of the sample size. So next are the selection biases in selected research designs and ways to reduce or eliminate bias. Selection bias in case control studies. So in case control studies, controls are used to provide an estimate for the exposure rate in the population. Control should be drawn from the same population as the cases, so they are representatives of the population which produce the cases. Therefore, selection bias may occur when those individuals selected as controls are unrepresentative of the population that produced the cases. So to minimize that, it is suggested to do population-based case control studies like neighborhood rather than hospitals, and control should come from more than one source. Selection bias can also happen in cohort studies. It is introduced when the completeness of follow-up or case ascertainment differs between exposure categories. To minimize the bias, high level of follow-up should be ensured throughout the study in both groups. So the healthy worker effect is specific to occupational cohort study where investigators seek to compare disease rates amongst individuals from an occupational group with individuals in an external standard population. For example, in a healthy of workers study in a workplace exposed to some occupational exposure comparing to health of the general population, so working individuals are likely to be healthier than general population that includes unemployed people. This is the healthy worker effect, probably because of the periodic health examination or more means to afford health care. Mortality or morbidity rates in the occupational group cohort may be lower than the population. So to minimize these, investigators should choose workers with different jobs performed at different locations within a single facility or choose an external population of employed individuals. Clinical trials can also have selection bias. It can be the allocation bias or the bias when there is a systematic difference between participants in study groups, or attrition bias where dropout is caused because participants did not find the medication effectively. So to minimize this, a good follow-up is warranted and always compute for the intention to treat analysis. So after discussing the selection bias and its type, we now go to the information bias. Let us first define what is an information bias. This bias happens when the information is measured, collected, and interpreted inaccurately. This leads to misclassification of subjects in one or more estimation of strength of association variables and distortions of the estimate of effect. So this slide shows the different types of information bias. Information bias can either be non-differential misclassification, random, or non-random. Random information bias occurs when classification of disease as status or exposure occurs equally in all study groups being compared. Probability of exposure bias misclassified is independent of the disease status, and the probability of disease status being misclassified is independent of exposure status. This may result in underestimate of the true strength of association. Non-random, on the other hand, occurs when the proportion of subjects misclassified differ between study groups. So that is the probability of exposure being misclassified is dependent on disease status, or the probability of disease status being misclassified is dependent on the exposure status. So there are five types of non-random information bias: recall bias, interviewer bias, observer bias, reporting, and prevarication. So let us discuss them one by one. Recall bias is a systematic error caused by the differences in the accuracy or completeness of the recollections retrieved by study participants regarding events or experiences from the past. Encountered in studies that have self-reporting as method of collecting information, such as in case control study where there can be differential recall of exposure between cases and controls. For example, in studies of risk factors for breast cancer, women who have this disease may search their memories more thoroughly than members of the unaffected control group for possible causes of their cancer. So those in the case group, those with breast cancer, may be able to recall a greater number of potential risk factors they have had been exposed to than those in the control group or the women unaffected by the breast cancer. So next is the interviewer bias. This occurs where an interviewer asks leading questions that may systematically influence the responses given by the interviewees. So the investigators may ask more leading questions about the disease or exposure and may prove differently about exposures in the past if he or she knows the subjects as cases. Interviewer bias distorts responses, especially when the characteristics relate in some way to the research topic. Interviewer bias can also affect the interviewer's ability to establish rapport with the interviewees, causing them to feel less comfortable given their honest opinions about sensitive or personal topics. Observer bias is a type of information bias that occurs as a result of the investigator's prior knowledge of the hypothesis under investigation or knowledge of an individual's exposure or disease status, which may influence the way information is collected, measured, or interpreted. So, resulting from the outcome assessor's knowledge of exposure status, hence, observers tend to measure more, collect more in those with disease than without the disease. An example is when a doctor, expecting a certain outcome based on their previous experiences and then unconsciously influencing their patients to achieve the expected outcomes. So another is reporting bias that occurs when individuals selectively suppress or reveal information for certain reasons. So researchers tend to report findings that show favorable results, sometimes also called the publication bias. For example, if you were studying how many people with blue eyes wear glasses and found that only 40% of people with blue eyes wear glasses, then it could be because they didn't include all the people with blue eyes in your study. It could also be because there are other factors at play that make fewer people with blue eyes wear glasses, such as those who don't wear glasses may not feel like wearing them. Prevarication bias occurs when a subject over or underestimates occur because of knowledge of the kind of treatment they have received. A subject may consciously feel the need to provide answers pleasing the interviewer or study coordinator, or may feel that there is some secondary gain from consciously misreporting their clinical status. So, under the prevarication bias, we have the Horton effect. It is also called the observer effect. So, this refers to the people's tendency to behave differently when they become aware that they are being observed. The increased attention focus of the workers as part of the study lead to the improved productivity and not because of the change in the amount of light. So to minimize information bias, researchers should either do blinding or standardization. So next is blinding. Uh, it makes sure interviewers and study personnel are unaware of exposure or the disease status. Observers should be blinded so that they won't over-observe the other group. Standardization, on the other hand, makes sure sources and methods of data collection are similar for all study groups. This can be achieved by training of observers, training of interviewers, data collection tools, and calibrated instruments. And for the last part of our lecture is the confounding variable. Confounding variable is a variable that is not included in an experiment yet affects the relationship between the two variables in an experiment. This is also known as a third variable or a mediator variable. For example, the figure on the right, suppose a researcher collects data on ice cream sales and shark attacks and finds that the two variables are highly correlated. This means that increased ice cream sales cause more shark attacks? That's unlikely, so the more likely cause is the confounding variable, the temperature. When it is warmer outside, more people buy ice cream and more people go in the ocean. So, what are the characteristics of a confounding variable? First, it should not be the independent nor dependent variable on the study. Second, the variable should be associated with both the dependent and independent variables. Third, it is not an intermediate step in the causal path between exposure and disease. And lastly, it should be regarded as a risk factor for disease outcome. So, what are the effects of having a confounding variable? First, confounding variables can make it seem that cause and effect relationships exist when they don't. In our previous example, the confounding variable of temperature made it seem like there is an existed cause and effect relationship between ice cream sales and shark attacks. However, we know that the ice cream sales don't cause shark attacks. The confounding variables of temperature just made it seem this way. And second, confounding variables can mask the true cause and effect relationship between variables. Suppose we're studying the ability of exercise to reduce blood pressure. So, one potential confounding variable is starting weight, which is correlated with exercise and has a direct causal effect on blood pressure. While increased exercise may lead to reduced blood pressure, an individual's starting weight also has a big impact on the relationship between these two variables. So there are three ways to control the confounding variables. We have the restriction or stratification, randomization, and matching. For the restriction or stratification, limit participation in the study to individuals who are similar in relation to the confounder. The disadvantage of this is it will be difficult to generalize the results to wider population if the study group is homogeneous. For example, the study on the right wanted to know if coffee drinking is a risk factor for having cardiovascular disease. The confounding variable here is smoking. Hence, in restriction, the investigator should limit criteria to non-smokers and confounder is eliminated. So, randomization is assigning study participants to treatment group randomly. This is the ideal method of controlling for confounding if done properly, because all potential confounders, both known and unknown, may become equally distributed between the study groups. By doing this, the investigators increase the chances that the two groups will have roughly similar characteristics, which means that any difference we observe between the two groups can be attributed to the treatment. Lastly, matching. This involves selecting controls so that the distribution of potential confounders is as similar as possible to the amongst the cases. So in summary, we have defined the internal versus external validity, differentiated random errors and bias, and explained how that they affect the research validity, describe different sources and types of bias and ways to control them, and lastly, we have explained how confounding variables influence the result of a study. So here are my references. Thank you for listening.